less likely to develop. They require the accumulation of several specific mutations to become inefficient. As a consequence of resistance, the IC50, the concentration of a drug necessary to reduce the replication by 50%, is higher in the mutant virus compared to wild type. The difference in replication between wild type and mutant virus is called change in IC50. Because primary mutations decrease the fitness of the mutant virus, in the absence of drug therapy, the wild-type, unmutated virus dominates the population. Mutants still emerge, but mutated viruses are less fit and persist only at low levels. The initiation of drug therapy exerts a selective pressure on the virus population. Wild-type virus is prevented from replicating. The viral load decreases. If a drug was given alone, mutants would emerge within a short period of time. Because they are not susceptible to the drug therapy, they would come to dominate the viral population, leading to treatment failure. Standard antiretroviral therapy therefore combines at least 3 drugs to target HIV simultaneously. Multiple mutations in different enzymes would be required for resistance to all drugs in the regimen. Once the viral replication is driven down to undetectable levels, the likelihood of such a mutant emerging is reduced dramatically. High levels of adherence are required for successful antiretroviral therapy. Subtherapeutic drug concentration due to poor adherence leads to an elevated replication rate. This increases the probability of resistance arising and a failure of the actual antiretroviral therapy. Improved drugs combine ease of administration and high potency against mutant viruses to help patients control the HIV infection.
That is what we call it as superinfection, or we also call it as reinfection. So it's just the same explanation of superinfection and co-infection. So how does this occur? So this is the host cell nucleus, which is for the CD4 positive T helper cell, which is infected. This is the host cell nucleus. Here we see one type of virus. You can see the green one. Say that is one of the virus, and this is a different mutated form of the virus. Now both of them insert their genome, their genetic material into the nucleus. Now both of them, they form another hybrid form of the virus, which has got a combination of the first virus and the second virus. And when this goes on to infect another cell, new viruses are being born. Now if you see the difference, the diversity in this and these two, they are different. So this is more like a hybrid form of a virus that you get. So this is how the combinations, the recombinant forms, they occur. So one form of the virus, one different virus, another virus, they get into the host cell, they make another new type of virus that goes on to infect another cell. If you see, you can see red, green, and all the entire combination is there. And then you get a totally a different hybrid form of virus. Now, this is a topic which we all are interested to know, which we call it as mother-to-child transmission or perinatal transmission, and also in relationship with malaria and tuberculosis. During contraction, during the process of the birth, during labor, we call it as intrapartum. Prepartum is before the labor, intrapartum is during the labor, postpartum is after the labor. So That's the word we use, Pata. So mothers are recommended to test for syphilis because syphilis is easily treatable with it's a bacterial infection and can easily be cured. And then there's another way the virus can cross the placenta when the mother's viral load is very high. The placenta is more like a trading post. See, the baby circulation, blood circulation system, or the baby's blood doesn't get into contact with the mother's blood. They're totally in different circulation route. But only the nutrients and the antibodies the baby is able to get. So the virus can cross the placenta in the event the mother's viral load is very high. Then breast engorgement, which is the swollen breast, and mastitis, inflammation and blockage in the milk duct and glands, bacteria might cause viral load to increase. So there can be bacterial infections. So blockage in the milk flow. That is why we recommend for exclusive breastfeeding, so that this kind of engorgement and mastitis doesn't occur. I'm going to talk more about exclusive breastfeeding. I'm just trying to put in a few points before that. And co-infection with malaria. See, any infection, forget malaria or tuberculosis, whatever the infection might be, at the end of the day, what you're trying to do is, you're activating the CD4 T helper cells. You're activating the immune cells. So what happens? So when you activate the immune cell because you have got malaria, what happens? HIV targets the very same CD4 T helper cell. That's the paradox of HIV. So then co-infection with malaria increases the viral load to 10 folds. And even after malaria is cured, the viral load can still be high. And the rate of sexual transmission of HIV remains high for a period of time. So tuberculosis also can activate cells and also cause an increase in viral load. So the ground rule here is, if you're positive and if you're a mother who is going to deliver a baby, you must, beyond any doubt, you must make sure that you don't get malaria. Okay, at whatever stage point it is, meaning you need to have all the precautionary measures like the mosquito nets and things of that nature. You need to take, because the problem is the viral load can go up, and as a result, transplacental transmission can take place. So as a result, the baby can also get the virus. So let's look into the context of malaria. What malaria does, as I already said, it activates the T cells. The T cell activation promotes HIV infection and replication, because when you're activating this, the T cells, what happens? HIV takes advantage of it. Now T cells are the commanders, the generals. HIV takes over the general. Then HIV viral load also increases, and during acute episode of malaria. Now the other way, if you look around, if you are HIV positive, HIV, what does it do? It impairs it because it infects all these T cells, and T cells are low in numbers. So when you get malaria and if you are HIV positive, what can be the scenario? The clearance of the malaria parasite takes much longer. You see both ways, it's a double-edged sword. So again, your immune cells are very low in order to fight the parasite. So when you have HIV, your immune system is already low, and even in order to clear the parasite, it takes again more longer duration. So in fact, the malaria could last much longer. So the severity of malaria is high. So that's why I've just put it, the contribution of malaria to HIV, and HIV, its role on malaria. So now coming to the issue of breastfeeding. So we all had this question in mind, probably, so that's why I just thought, let me try and explore this avenue, because this is the most sought after topic and most talked also. So assuming the baby, let's forget about the status part of it. If the baby is not given any breast milk, so see the chances of the baby having deaths as a result of diarrhea. The diarrheal death is very high for all infants in general, and infants less than 2 months, the diarrhea mortality is very high. So the baby can die of two things. One is pneumonia, and the other one is diarrhea. Let's forget about the issue of HIV. At the end of the day, we need to save the child. So the issue of diarrhea is one of the reasons why we have thought about exclusive breastfeeding. And now, why exclusive? If It's a bit of science, we are going to come to that. But before that, you need to keep this point. So we are reducing the diarrheal death, the death due to diarrhea, as well as through pneumonia. That's the same thing. You have seen mixed breastfeeding is associated with diarrhea and increased intestinal permeability, and the baby can also die of pneumonia. Also, mixed breastfeedings are partially saturated, and the baby doesn't suck the breast milk efficiently. As a result, there can be blockage, which we saw, mastitis and swelling of the breast, and also bacterial infections can take over. So these are some of the reasons why we consider exclusive breastfeeding. And then the human milk has also got a compound called as oligosaccharides, and these oligosaccharides line the membrane of the baby's intestine. As a result, it also destroys the bacteria which are there. But if you do mixed breastfeeding, and what happens is there is two different issues. One is the other kind of foods that you give and the breast milk. It makes the intestine more permeable, and it causes bacterial and fungal infection for the baby. But now here, coming from the science point of view, why do we have to exclusively breastfeed also? There's another issue. Remember I told you about the broadly neutralizing antibodies. So if assuming the baby is not, the mother is not an antiviral therapy, and mother is also having high viral load, consider all the worst case scenario. Still, the chance of the baby being positive is only 40%. 4 out of 10 is the chance for the baby being positive. And there is a 6 times chance out of 10 that the baby will not be born positive. That is another probability. So, the point here is what the mother has got kind of antibodies which is called as broadly neutralizing antibodies. What broadly neutralizing antibodies is, I'm just trying to explain. Antibodies, they are like Y-shape. So what happens, assuming this is the virus, the antibodies are able to neutralize by sticking on the outside of the virus. Well and good, so it has neutralized. The virus is mutated, it has changed its surface proteins, glycoprotein. So the amino acid sequencing on the GP120, it has changed. Now, let's assume now this has become red color. Still the same antibodies are able to bind. Then again it has changed, it has mutated. Again the antibodies are able to bind. So some mothers have got these broadly neutralizing antibodies. So there is a chance, okay, there is a 60% chance there. Now what if the mother starts taking antiviral therapy? We have already seen in the context of sexual transmission, the transmission doesn't occur if it is less than 1,500 in the sexual situation. Remember we saw one slide before, study in Uganda, less than 1,500 viral load copies, transmission doesn't occur. So, putting that also into the context, if the mother is put on antiviral therapy, what happens is, plain and simple, the chance of passing on the virus to the baby is almost zero, it's diminished. Hello? So the chance of passing on the virus is also diminished. So that is one aspect. The other aspect is broadly neutralizing antibodies. The other aspect is the baby is exclusively breastfeeding, so there is no bacterial infection or mastitis or swelling of the breast. So all these factors collectively put together through exclusive breastfeeding, we see that the chance of transmission is very much diminished, but it can still occur, but that probability is too little. So that is one of the issue. But of course the baby can be given other kind of medication like syrups or vitamins or rehydration salts. Those are exceptions, but otherwise exclusive breastfeeding has been shown, and a lot of trials have been done, cohort trials and tests have been done even in Botswana, even in Zambia, that it has been shown that transmission almost never occurs if the mother is exclusively breastfeeding, and the mother has to be on antiviral therapy to keep the viral load to undetectable levels. So either sexual transmission or transmission from mother to baby hardly occurs. So that's the issue of mother to child transmission. So here we see this, the baby is secure there, and this is the placenta. So the baby doesn't come into contact with any of the mother's fluids. So, this is before the baby is born. Transmission can occur through ruptures in the placenta if you've got, we call it, if you have, the mother has got malaria. So that kind of situation can compromise the chances. Then intrapartum transmission may occur from mother's genital fluids entering into the baby's mucosa through the eyes, through the mouth, and that through genital fluids from the mother can come in contact. But in the context of HIV, the viral load is undetectable, and even this kind of possibility is almost ruled out. Now this is a slide showing both cases the mother is positive. In this case the baby is born negative, and in this case the baby is positive. You find that the mother's antibodies are there in the baby in both situations. In both the situations the mother's antibodies are there. So if you do the standard antibody testing, which we do at our VCT centers, of course the baby will also show, both the babies will show positive, because we do the antibody testing. We don't do the PCR RNA testing, or the PCR DNA testing comes in only later. But initially we find that the baby has got the mother's antibodies. So it's around, in a period of 18 months or so, is when the baby will start developing its own antibodies. So that way you can test the baby for antibodies only after around 18 months. But before that, the only way of knowing is using the PCR DNA test, which you can do it after, say, around a month after the baby is born, or somewhere in that phase, which is called the PCR DNA, polymerase chain reaction DNA test. Here we are looking directly for the piece of the virus itself. So that's the scenario. So doing an antibody test for a baby who is born positive before 18 months may still show positive, because the baby is carrying the mother's antibodies. And then when a baby is born, the baby is also given what is called as pediatric antiviral drugs, just as a prophylaxis, which is a zidovudine, within 48 hours of birth and continued for another 6 weeks. In addition to zidovudine, in some countries, like in India, they also consider giving nevirapine. But mind you, these are just 2 drugs. These are just 2 drugs. And it should not be continued if you find out that the baby is positive. At that time, you need to quickly change over to the triple drug cocktail, because antiviral drugs are 3 drugs. Now this baby is given as a more you could put it like a post-exposure prophylaxis, assuming if it has been having the virus. So through this intervention of zidovudine, for 6 weeks after the child is born, 48 hours after that. And this is what we also do in most developing countries in Africa. But in India also, in some situations, they also consider nevirapine along with it. But as I told you, these are just 2 drugs. But now if you find out that the baby is positive after the PCR DNA, you need to quickly revert to the triple drug cocktail. Here there's a very interesting scenario. I'm sure everybody is interested in this. How is it that the 30 days old baby was given antiviral drugs, and it never, the virus is not to be seen? What happened here is, soon after birth, within 30 hours of birth, the baby was given a triple drug cocktail. It was not, that baby was not given this kind of routine procedure, because if you're hyperactive on the TH1, what happens? You can also start getting autoimmune disorders. Your healthy cells are being destroyed. So you should not be hyperactive on TH1. And here again we see what is called as TH2, which is the antibody-mediated immunity. In antibody-mediated immunity, your tissues and cells are not being destroyed, but then you will start getting allergies like asthma, this kind of allergic reaction you will start getting. So if TH2 is hyperactive, so this is called as antibody-mediated immunity, or another more technical term is a humoral immunity. So humoral immunity is the antibody immunity, and cellular immunity is the one which has got a good robust CTL response. So our aim is to balance both TH1 and TH2. So if it is hyperactive on TH1, it is pro-inflammatory. So it's going to kill the pathogen, but it will also destroy healthy tissues. And then here again, TH2, it is anti-inflammatory, but it will not. It will protect the tissue, from tissue damage, but risk of pathogen survival. So both ways, you need to balance both. For example, people tell you that you take, what is this, very famous, green tea. But if you're already TH2 hyperactive, if you take green tea, the effects will be detrimental. It will be a negative effect. So you need to be careful, like Somebody says, HIV, start taking green tea. But see the effect of green tea. So why I wanted to give all those examples of cell-mediated immunity and the humoral immunity or the antibody-mediated immunities so that you understand the science behind it. So that's why I just didn't want to jump into the slide without going through those slides. So you can see, for example, turmeric, green tea, grape seeds, all these are Th2 hyperactive. So if you're already, hyperactive to Th2 and you take these stuff, it will have detrimental effect. And these things for Th1, maybe you're not familiar with some of these, but anyway, these are the people who promote those boosters. You see, this has got this stuff, ginseng. Oh, take this ginseng, or take this other herbs which you see over here. Take this golden seal plant. You take this. This is good for you for HIV. But we don't know what kind of a person you are, whether you are a Th1 person or a Th2 person. So you don't take stuff anyhow. I hope it's quite clear here in this. Now, here we are seeing some people who progress to AIDS much quicker. These are rapid progressors. They are very small in number. This is a normal curve that you can see here. And these are average progressors. Their RNA is still quite high. And then these are slow progressors. They have got a good CTL response. The CD4 is quite high, you can see here. These average progressors are not very quick progressors, but they also have a quick decline in the CD4. These rapid progressors are quick progressors. The first one over here, rapid progressors, they are very quick. And you see the RNA there. You see the RNA copies there on top, which is very high, and the CD4 is declining very rapidly. And these guys are non-progressors. You find that things are quite good here. The CD4 T helper cell responses, it remains quite high, and the viral load is very low. It has come down to almost undetectable levels. And these are long-term non-progressors, but they still have the virus. Why? What is the reason? This is what we are going to explore now. So, everything, I think this has finished the battery now. Okay. Now, everything comes down to how robust your CTL response is. If you see here, the first one, the CTL response is not good. It's a weak response. That's why you find the viral load, the viremia is high. And then you find over here, slow progressors, they have got a strong CTL response. That is why it's low. So this is what we call as the set point. Remember, we have been talking about the set point several occasions. So if you have this kind of a higher set point, which means you're a rapid progressor. If you have a lower set point, you are a slow progressor. So if you do a viral load test, when someone say after 6 months after acute infection, then you will know your set point. So there are ways to know how we are going to progress to AIDS. And here you are going to see the CTL response. You can see this is the region. So everything depends on how your CTL response is. You can see the cytotoxic T cell coming there and trying to balance up things. Now from the high viremia, it brings it down either here or here or here. So that is how the disease progression takes place. And some people are elite controllers. These people are the ones who have the virus, but they're able to live with the virus for a prolonged period of time. These are long-term non-progressors. These are highly exposed but uninfected people. They are still HIV negative. And then there are some people who are rapid progressors, which is RPS, which you can see right on there, on the extreme right. See, they can even progress as early as in 2 to 3 years. So there are different diversity. So here I will just try to bring in the reason why some people don't even get AIDS and some people progress very low. As I've told you, HIV uses 2 entry points. One is the CD4, which is the surface receptor, and then the other one is what? CCR5. We have already seen that CCR5. Some people have mutations on the CCR5, which is acquired from both parents. These people are called as homozygous. Heterozygous, they get mutation from one parent. These are called as heterozygous. So homozygous people, they've got deletion in 32 base pairs on the on their CCR5. So what happens is, it's like they don't have the CCR5. Now let's think this way. Why can't we all remove our CCR5? We don't need it. People can live without CCR5. So if we can try and find a mechanism where we can, I'm just trying to explore options. Okay? So if we get rid of the CCR5, we are not going to get HIV. So the problem is, it is proven that some people don't have this or lack the CCR5 gene, which are called as delta 32, and these people don't get HIV in the first place. If your